I first of all, I would like to thank the organizing committees to invite me here. It's a big honor for me to be here in Egypt. This is my third visit, if I'm not wrong, and it's a real pleasure, and I always enjoy. I wish I could have a little more time than which I have at the moment. But what I can say that I do not know how to start the naming. So I have so many friends. I have so many friends from from Egypt, and particularly from the MENA region. And here I see my very dear friend, Professor Abdul Al Said. Adel is probably not here. Professor Mizbah, Abdul Basit. So I will not go by name because I think that then I will be spending the whole day using my name. I said that my dear colleagues, dear friends, my brothers and sisters, in the name of Islam. So that's how I address. And in the beginning, that what I could say about the IDF, that in terms of the 100 years of centenary of insulin, that we have already published one special issue in the DRCP, Diabetes Research and Clinical Practice, on 100 years of insulin. We have, from the IDF side, we have worked very hard for the WHO to have a kind of resolution, for the universal access to insulin, which was difficult. You know that big countries, unfortunately, they do not support such an initiative. This is because of owing to their business interest, because many of the insulin producing countries actually is not in favor of it, because we wanted a kind of transparency in terms of its cost, and they refused to give us the transparency in terms of the cost transparency. And so we had some difficulties. We failed in the first instance, and then we actually pursued a poor country like Bangladesh, which I'm originally from, and the Bangladesh government agreed, and then we failed finally. And then the Russian Federation actually came up with this proposal, and this was actually published in May last year. So we have a WHO resolution about the universal access to insulin. And this is a big achievement, I think, for all the people who are working for diabetes, not only for the IDF. And as a representative from the IDF, I would like to say there are two things that I see the worries in our region globally, that we are a member of the ADA, we are a member of the ESD, we are going for these meetings or not. I have one simple message to everyone, that we have many friends, but we never forget our parents. You are only represented globally through the IDF, not through the ESD, not through the ADA. But I'm not saying that I have anything against these organizations. They are also the member of the IDF. But I say that do not forget that IDF is your organization. IDF is a federation of 230 member associations globally from 172 countries. So the basis for global diabetes, basis for global IDF is you. And there is no IDF without you. And so your representation globally is only secured through the IDF. So that would be the kind of information that I would like to say. Regarding this 100 years of insulin therapy that I will talk. This is a paper that we have published. We have published in this same journal. We called Race, Ethnicity, and Challenges for Optimal Insulin Therapy. This was published in 2021. And actually, Abdul Basit is also one of the co-author. We have authored from actually 11 countries, including Stephen Calaguri, Andrew Bolton, myself. So we all saw the importance of considering the ethnic variation and the challenges in insulin therapy. And this is something that I would like to say, that you will say that in my presentation, I will be probably a little critical of us as doctors and scientists, whether we are doing enough. I will be a little critical in terms of the social responsibility of the pharmaceutical industries, that the people should have insulin, access to insulin, that it is also, the industries are not only to make profit, they also have a social responsibilities. So I will be talking a little bit, but it doesn't mean that I have anything against the pharmaceutical industries or my colleagues who are here. So please do not misunderstand me, even though I will be critical on my presentation. So I think that we can go to this slides to 100 years of insulin. I see that here. Yes, you can see that this slides is defined as 100 years of insulin therapy, ethnicity and challenges. So this is the article, so which I'll be discussing more in the light of today's discussion. Okay. So in the initially, I'm talking about a little bit of the history, that we believe that as we have, I have seen that some of my previous speakers has already shown this, because many of us believe that the insulin was discovered 100 years back, which is not correct. Insulin was discovered much before. In 1869, Paul Langerhans, a medical student, as has been said, he has already talked about the cells within the pancreas. And in 1916, the Romanian professor Nicolae Paulsen developed an extract of the pancreas and shows that it lowered blood sugar in diabetes dogs, which was in 1916. Eugene Olli discovers that the islets of Langerhans produce insulin, and that the destruction of these cells resulted in diabetes. This was found in 1901. The next one, please. Can I have control, or which one is down? Okay. Thank you. So so comes the insulin industry. I'm talking about a little bit of the NPH, an intermediate acting insulin, is marked by Danish pharmaceutical company, the Novo Nordisk, in 1950s. And in 1955, the insulin sequenced by British biochemist Frederick Sanger, and was the first protein to be fully sequenced. In 1958, Sanger received the Nobel Prize. In 1963, insulin becomes the first human protein to be chemically synthesized. So in short, in brief, what we can say that in 78, the biotechnology from Gentech used the recombinant DNA techniques to produce the synthetic human insulin, and followed by, in 1982, the synthetic insulin is renamed as human insulin. 1985, Novo Nordisk produced the insulin pen delivery system. 1992, the Medtronic releases the Mini-Med 506. And 1996, Eli Lilly marketed the analogs of insulin, and 2000, more than 470 patients with type 1 diabetes received the islet cell transplantations. So this is a little bit in short of the insulin industry that has happened in our time. And then the question that comes, insulin with 100 years and access to insulin, that what has actually happened? We see that recognizing that insulin is an essential medicine, but concerned that despite being discovered 100 years ago in 21, globally about half of the people in need of insulin have no or irregular access or unacceptable inequalities between and within the countries. 50% of the people globally do not have access to insulin, those who need it. And more importantly, that if you look at geographically, that while in sub-Saharan African countries, this number was found to be only 1 in 7 people. 1 in 7 people have regular access to insulin. So this is what we have achieved in 100 years. While the industry became $100 billion business. Insulin business of today is $100 billion. 3 companies dominates 97% of the world market. 3 companies, actually 97% of the world market is dominated by 3 companies. And they are the companies who objected this WHO resolution. Where is our social responsibilities? Where we colleagues as doctors, scientists are raising this issue with our partners, we should cooperate with them. We should cooperate with the pharmaceutical industries. I have no objection with that. But we also have a responsibility to tell them that what is needed on the ground. Are we doing it? Lawrence in 1922 declared that now the modern discoveries, particularly insulin, has completely changed the outlook. There is no reason why a diabetic person should not, if he can, be taught to do so, lead a long, normal life. Have we secured it? We need to ask ourselves critically that we celebrate with so many congresses, we celebrate, but at the end of the day, what we celebrate? If we look at these gaps in desired outcomes, the numbers needs in diabetes care. As you say that out of first of all, the 50% of the people are diagnosed. Globally, that we have, so that means that we have a kind of national plan we need for screening, which is lacking. We do not screen people. There is very few countries where you can have a kind of national data in terms of the prevalence data, for example, globally, nationally, other than some pocket surveys. You have done some pocket surveys in, for example, in one part of Egypt. Does it mean that this is the national prevalence for Egypt? No. It varies within the countries a great deal. 50% of the people are diagnosed, of whom 50% receive care. Those who are diagnosed, only 50% is receiving the care. Of those who receive care, about 50%, they achieve the treatment targets. And of those who receive the treatment targets, 50% or 6% of them actually achieve the desired outcome. So this is the clinical fact. If you look at this A1C, for example, glucose control, we can see that there are about 30% of the people, patient varies from 30 to 45% actually receive the targets. Why it is so? We should think critically that what we are doing in our practices. If you look at the cost production of the government procurement and public and private sector, patient prices for human analogs insulin based on 43 countries. You can say there is a great variety. We can agree that for both for human insulin and analog insulin that we see a great variety in terms of the government prices and the private purchasing. Government prices, I know you all agree that the public sector, so we don't have always the availability of insulin, which is where the price is a little lower. So we see that why there are so disparities. It's the same companies, as I said, that 3 companies actually control 97% of the world market. So why these disparities exist? This is coming again from Sub-Saharan Africa, because we said that about 1 in 7 people in Sub-Saharan African countries actually have a kind of secured supply of insulin. And you say the public and private sector, how it differs from each country. These are the published data from 2021. So it's not old data. So this is the fact that we are facing today. I'm a very much part of this diabetes community. I'm also a colleague, a scientist, and also leading our International Diabetes Federation today. I'm very much together with you. But I'm trying to bear this grave situation together with you. If you see this, for example, the rapid insulin analogs. So this is the kind of the medical reimbursement trends to cover the insulin production from 1991 to 2014. So you see that rapid acting analogs, it is receiving the highest reimbursement trends to cover insulin products. You see that nowadays that I will come probably at the end, that I'm thinking to revisit our IDF guidelines for type 2 diabetes treatment. The cost is, that many people are saying that can we go for the best option because people cannot afford it. Because why people cannot afford it? Because of the disparities that we saw, the cost of production is similar, but selling prices are so different from countries to countries, and also from the government sector to the private sector. And the reimbursement situation that you see, that is making it impossible for our people to have access to the life-saving drug like insulin. So insulin therapies, in brief history, the first, it was formulated in 1922. Now I'm talking about therapy. Was also weight-based and calculated conservatively to prevent the hypoglycemia and preserve limited amount of insulin available. So this was the dose that was based on the body weight to insulin. In 1982, this based upon clinical experience on human regular insulin, Schuyler et al. Suggested that a total basal dose, TBD, should be about 40% of the total daily dose. Then it comes 1999, the rule of 3 was proposed to estimate the carbohydrate to insulin ratio, or the CIR, that you all familiar with. Current formulation of estimating correction factor, the CF, are based on suggested by Davidson et al. Of the 1500 rule, later modified to 700. The CF was 700 to TDD, or the total daily dose. So this is the brief story that how the insulin therapy was developed. Now you all know these concepts of type 1 diabetes, that's basal requirements, so it's mainly we are thinking of two things, that is the weight-based and the carbohydrate factors. That is the basis for our insulin calculation. If we look at the people with diabetes, you see that we have most cases of type 2 diabetes are in non-isolated population. We're not talking of the ones that are right. You see that you have this diabetes component pathways, the obesity, insulin action, insulin resistance, adipose tissues dysfunction, inflammation, fat distribution, and beta cell function. If you distribute it to the people with diabetes, they are not equally distributed. They are not equally, but we are treating them equally under the same formula. As you know that WHO is now changing the type 2s. They are now coming up with the subtypes of type 2 in their definition, because they are seeing that the differences in terms of how much the obesity is affecting, how much the insulin is action, and how much insulin resistance, adipose tissues dysfunction, and so these are very different. You see that these people are not equally affected by all these factors. If we look at the diabetes prevalence by BMI, that is weight-based that I'm talking about, that if you see this BMI, the European, the Mexican, the South American, the Russians, African, Mid East, Indian subcontinent, Central Asia, Southeast Asia. So you see, this obesity, this weight actually is affecting the prevalence, diabetes of prevalence, very differently in different populations. But we are using the same formula for all population. So if you think of from the evolutionary point, now I'm thinking of the evolutionary point. If you say that, you see that from an evolutionary perspective, human blood glucose levels have likely evolved towards their current equilibrium over thousands of years as a response to genetic or environmental perturbations. The stability of blood glucose regulation has developed through a hyperbolic function of two variables, that is the insulin sensitivity and insulin response, probably. And this global migration that we have, the migration is not new, that I'm living more than 35 years in Norway, coming from Bangladesh. This trend is nothing new. Humans have always migrated. Have behavioral changes, have made some adjustments in factors that influence the insulin sensitivity and secretions such as body size, composition, energy expenditure, storage, and heat production. As these factors changed, novel genetic variants, the mutations have also pushed some subpopulation to different points of stability. And this is very important if we think of for example, the optimal effect of the effectivity of insulin therapy. We talk about the genetic predispositions. This is the data that was taken, the racial and ethnic differences in the burden of type 2 diabetes. You see that the East Asians, American, European, and African, the genetic risk score was actually calculated by summing up the number of risk alleles weighted by the published effect size across 63 published variants in different racial ethnic groups. You see that how this genetic score differs in terms of the risk for diabetes in different population. So genetic predisposition that we talk about, which actually I say that very often that when we do not have any answer to a question, we say that Allah knows it best. And in medical terms, when we do not know the answer, we say probably it's because of the genetic disposition and because nobody knows what is it, but it sounds very scientific. We have not yet identified any genetic markers other than the monogenetic form of diabetes. For type 2 diabetes in general, we have not identified any genetic markers that these are the genetic markers that is responsible for type 2 diabetes. However, I'm not excluding the possibility that there is a relationship, but I'm saying, having said it, there is a big varieties across the ethnicities. This is a paper. I think this slide is quite interesting, that what I see, that here you see this, for example, the insulin sensitivity index and acute insulin response to glucose. And it's three different populations: the Africans, the Caucasians, and East Asians. The East Asians here, we're talking about Japanese, Taiwan. This not for example, Bangladesh or India, which is. So what we see that, for example, if you look at this insulin sensitivity index, that you say that Africans have significantly lower insulin sensitivity. If you look at this, for example, the Africans, which is the white dots, that you can see that they have the significantly lower insulin sensitivity and higher insulin response than other two groups. So they produce a lot of insulin, but they have also very high insulin resistance. On the other hand, if you look at the East Asians, their insulin sensitivity is quite good, but they produce very low level of insulin. Any changes in this equilibrium? So we can say that why we see that there is a kind of explosion of this of diabetes today globally. This probably can give us an explanation that anything happens in the East Asian population, that where the, for example, adiposity, that which we see more commonly, that if the adiposity increases, the insulin resistance will increase. They produce lower level of insulin, and if the insulin resistance increases, there will be an explosion of diabetes. In the African population, it is the same, but we see that in the opposite way, because they have higher insulin resistance, but they also produce a lot of insulin. In the Caucasians, however, as we see that they have the lowest rate of diabetes globally, and they are actually falls in the middle. So they have an intermediate level of insulin resistance and good level of insulin production. So this picture actually tells us, give us an explanation that why we see this explosion of diabetes globally. This is a paper from African women. There's a Black African and a white European. You see that, for example, the pathogenesis of type 2 diabetes and risk in Black African in South African perspectives. You see that insulin secretion and hepatic insulin clearance is clearly different from this Black African to the white European woman. And this is a kind of pathogenesis of type 2 diabetes in Black Africans and the South African population. You see that here is what is that? They have the gluteal fat that causes the hypertrophy, fibrosis, inflammation, and the glucagon receptors problem, leading to the hyperinsulinemia and beta cell response. So it's a typical situation that we see in the African population. But if we look at, for example, the Asian population, you see that, for example, there is a big difference in terms of the this, for example, the rapid modernization changes of environment, lifestyle, unspeakable diabetes mellitus in the obesity. So we have a low BMI, large waist circumferences, put Asian people at high risk for beta cell dysfunction and insulin resistance. We see that there are differences. If you look at this, for example, the fat distribution, that there are two individuals with some body fat percentages, age, sex, and BMI of 24 kgs. They have identical BMI of 24 kgs. You see, we are talking about the weight. Because weight, again, I'm saying holding the weight because weight is the basis for our insulin calculation. If you look at this, for example, on the left is, on the right is the Asian subjects. With the same BMI, we have 3.7 liters of visceral fat, whereas in the European Caucasians, we have 1 liter of visceral fat. And if you look at two individuals with the same body fat percentages, we talk about not only the same identical body fat percentages, sex and waist circumference of 84 centimeters, we see that the Asians have 4.2 liters of visceral fat, and Caucasians have 1.2 liters of visceral fat. Can we still use the same formula for the insulin calculation? This is also the insulin response to oral glucose tolerance. That is, we see this, how it differs in terms of Caucasians and the Japanese. Insulinogenic index and HOMA insulin resistance, you see that is significantly different in these two populations, the Caucasians and the Far East, that is the Japanese population. This is the blood glucose that you can give given the same carbohydrate load that we talk about, carbohydrate factor, the CF factor, that given the same carbohydrate, you see that the Caucasian and the Chinese, that after 120 minutes, after 2 hours, that these Chinese have significantly higher level of glucose production compared to the Caucasians. But we gave the same insulin therapy. We calculate, we have the fraction for this carbohydrate ratio factor is similar. We have seen the percentages of participants with HbA1c less than 7% by race and ethnicity. I think that's it's very, very different. I'm sorry that it's not coming, this picture. Yeah, this one. That it has also differed by different population. Let's go to this effectivity on racial ethnic differences in achieving hemoglobin A1c less than 7% with more than 12 weeks of insulin therapy. We have the basal. We have this insulin Lispro mix 75-25 and Lispro mix 50-50. You see that, for example, if we look at this Caucasians, Latino Hispanics, Asian, African descent, how it differs. This target, achieving the target is very different given the same therapy to these four ethnic groups of population. And this achievement of glycemic, blood pressure, lipids, we see that all differs in different by ethnicity. So what we observe in conclusion that we can say that diabetes prevalence, complications, mortality differ significantly by ethnicity. Genetic risk score differs significantly by ethnicity. Body composition differs significantly by ethnicity. Insulin resistance by BMI differs significantly by ethnicity. Insulin sensitivity and insulin response differ significantly by ethnicity. Insulin response to glucose carbohydrate differs significantly by ethnicity. Glucose control by HbA1c differs significantly by ethnicity. And with all this knowledge, we are not critically asking, can we use the same formula across all ethnicities to give the insulin therapy? So what I would say, that take-home message, we see the East Asian, the Chinese, Japanese, the Koreans have lower insulin production, but high insulin sensitivity. South Asians like Bangladesh, India, Pakistan, and I think the South Asians will also bring the Middle East, pretty close to it. It's relatively low insulin production, but high insulin resistance due to high visceral fat. The Africans have high insulin production, but high insulin resistance, and Caucasians have good amount of insulin secretion and lower levels of insulin resistance. So this is the, when we put them together, then we see that that's the way the people differs physiologically. In conclusion, I would say that today the international guidelines addressing racial, ethnic, or specific clinical practice recommendations are very limited or do not exist. It is evident that treatment response to insulin therapy by race, ethnicity varies and warrant further large trials, including the efficacy and safety of different regimen of insulin in diverse population. All diabetes is increasing, and particularly in non-white population. We need larger body of evidence to better understand the impact of race, ethnicity, of the different response to insulin therapy on the safety and the efficacy. And insulin therapy guidelines based on trials, mainly in white communities, is less likely to secure the efficacy and safety of the people with diabetes and other ethnic groups. My dear colleagues, we bring the best evidence that was published in the Western medias based on the Caucasian population. And then we said that this is the best evidence that we have. We do not critically ask that whether these findings, they are very good science, but whether this science is applicable to all population. Isn't it our responsibility, isn't it time for us to develop our own findings so that we can build up our own guidelines? The biggest problem for us to build up our guidelines is because we have very little evidence. That is the evidence being published. So I will encourage my dear colleagues and friends to focus on research so that you can publish your data so that a guideline can be developed based on evidence from your data, not from the Caucasian population. So I think this was the virtual Congress for 2021. This is an old, but I would also welcome you that IDF will have this World Congress this year in December 4th to 8th of December 2022 in Lisbon. So I hope most of you will be able to participate there. So with this word, I will say thank you and